Hello everyone, welcome to our Zoom meeting. Today we will have 4 topics. Dr. Eiman and her team will be presenting. So when you are ready, Dr. Eiman, please go ahead. Thank you so much. Assalamu alaikum. Welcome to the Zoom meeting. We will discuss 4 topics today, and Dr. Eiman and her team will be starting. Thank you so much, Dr. Eiman. Please go ahead when you are ready. Dr. Eiman, are you with us?
Yes, I'm here.
Okay, thank you.
Perfect. Assalamu alaikum, everyone. And today we, as the great team, we're going to be presenting. I apologize if you hear any noise on the background. So I apologize for that. Okay, I'm going to start presenting the first topic. I'm just gonna share my screen. Just bear with me 1 minute.
That's fine. You can take your time.
I'm trying to share my screen, but
Do you want me to share and then you can just present?
oh yes, I'm trying to share my screen. And are you able to see my screen right now?
No, it's blank. Or... I can do it and you can just present if you don't mind.
All right, sure.
It's the same slides, right?
I made my own slide.
Oh, okay. Then in that case, do you mind if you share it with someone?
Yes.
And
You can send it to me?
Okay, I'll make a final trial and then send it to you. Just
Okay.
okay. I think you can see me now, correct?
Yes.
All right. I apologize for the technical difficulties. Um, I think I'll go to the next presenter until I figure out this technical difficulty that I'm going through.
Okay, sure. I can present. Can you stop sharing the screen?
All right. I apologize for that.
No worries. So Dr. Rayan will be presenting the second topic. Go ahead, Dr. Rayan, when you are ready. Thank you.
Okay, thank you very much. Can you see my screen? And can you hear me?
Yes.
Okay. Welcome all. Thank you for this opportunity, Dr. Nadir, and welcome all. Today, I'm going to present the updated NICE guideline for type 2 diabetes management. It released in February 2026. I am Rayan Mohammed, and I will be your presenter for today. So the main difference between the past and new guideline is that the previous one was focused on the one size fits all. It mainly focusing on hemoglobin A1C targeting to be within the appropriate range. But the updated guideline, it's personalized care based on the patient, the comorbidities, and the patient as all. For the new updated guideline, we focus on the cardiovascular risk, renal function, and prevention of cardiovascular and renal function deterioration, patient comorbidities like obesity and frailty status. Management must be tolerated to be to each patient comorbidities, frailty status, cardiovascular, renal risk factor, life expectancy, hypoglycemic risk, and patient preference. It's mainly a decision making based on each patient, a multidisciplinary approach. One of the important difference in the new updated guidelines is the standard hemoglobin A1C target. In the previous one, we were focusing on the standard target of hemoglobin A1C to be 6.5 for all individual. This have been changed. It is 6.5 for a patient with no comorbid and no hypoglycemic risk. But patient at increased risk of hypoglycemic attack, that's patient with on repeated hypoglycemic attack or patient on insulin, sulfonylureas, the target is 7, hemoglobin A1C to be 7. And we intensified the management for patient with hemoglobin A1C 7.5 or more to step up in the management for targeting. And the target is relaxant and for older and frail individual, where there are the long-term outterm based on the patient life expectancy, cognitive function, and so on. So patient that is old and they have an repeated cognitive impairment, we can tolerate hemoglobin A1C targeted to prevent the deterioration of the function, not on the target to the well hemoglobin A1C. And an important update in the guideline is introduction of SGL2 inhibitor, sodium glucose co-transporter inhibitor, the first line management for all patients with metformin. So in what we all know, and in the previous and all past guidelines, that we started with metformin for all patients. But in the updated guideline, SGL2 inhibitor showed to be decrease the risk of comorbidity and cardiovascular renal deterioration. As we know, patients with diabetes at increased risk of developing cardiovascular condition and renal impairment. So SGL2 inhibitor should be started as early as diagnosis of hemoglobin A1C based on the 2026 guideline. And it is not for targeting hemoglobin A1C to be within the appropriate range only, but it also to prevent the comorbidities. As I said, SGL2 showed to decrease the risk of cardiovascular and renal deterioration in patients with diabetes. That is why we start even if hemoglobin A1C is well controlled on metformin alone. And this is a straightforward from the NICE guideline, updated NICE guideline. People with type 2 diabetes, even if they didn't have any comorbid or no relevant comorbidities, we started in metformin and SGL2 inhibitor. And if the metformin is contraindicated, we start is monotherapy with SGL2 inhibitor. And as we all know, in the previous guideline, it was metformin, then sulfonylureas or insulin-based or DPP-4. This was changed. And now if we cannot give metformin, we started with SGL2 inhibitor for all patients. Why? Based on the meta-analysis and systemic review that conducted a combination of metformin with SGL2 inhibitor was more clinically effective at reducing hemoglobin A1C, weight, and cardiovascular events. Event than any others therapy combined metformin with combining metformin with one other's medication or metformin alone. The cardiovasculars that have been mentioned, it include cardiovascular mortality, myocardial infarction, non-fatal stroke, and hospitalization of heart failure. The evidence also shows that the canagliflozin and dapagliflozin reduce the risk of end-stage renal failure. And for this slide, I just want to mention, for those are going to examine step 2 and step 3 in the upcoming period, this is a high yield area that is shown to be tested in the exam, as they give a long scenario of patients with diabetes and have well-controlled hemoglobin A1C. And then they ask what medication to be added and just search for SGL2 inhibitor in the options, and that will be correct, inshallah. And established cardiovascular disease for patients who are already established cardiovascular risk factor or have a previous attack of cardiovascular disease. The medication for this patient include metformin, SGL2 inhibitor, plus subcutaneous semaglutide. It is 1 milligram weekly for additional benefit. This showed to reduce the major adverse effect of cardiovascular disease. It reduced hospitalization for patients with heart failure and progression of renal failure. Also, patients with heart failure management, SGL2 inhibitor it showed to improve the symptoms regardless of the ejection fraction. So if we have patient with heart failure, preserve or reduce ejection fraction, SGL2 inhibitor should be started for all diabetic patients. It's also recommended to be established even the patient at risk for developing heart failure. If it is now asymptomatic, but it's high risk to develop heart failure, it should be started as well. As we see here, the SGL2 inhibitor classically demonstrate constant benefit across the ejection fraction spectrum, reducing hospitalization and improve the symptoms. Early initiation, even before the heart failure diagnosis, and at-risk individual is emphasized. I just want to mention that SGL2 inhibitor is worked by increased renal excretion of glucose. That is a kind of diuretic effect. So patient started with SGL2 inhibitor can develop dehydration. So when it started, you should follow it closely. And it also showed to reduce the ejection fraction. It didn't need to stop the medication, just follow it closely and monitoring. Unless renal function is severely deteriorated, then you need to take action. So for just for summarization of previous two slides, patient with increased cardiovascular risk and or develop cardiovascular disease and patient on heart failure or at increased risk of heart failure, SGL2 inhibitor should be started to decrease the deterioration and improve the patient condition and decrease hospitalization. Then we have the patient with chronic kidney disease. As we said before, SGL2 inhibitor, it showed to decrease the risk of developing renal failure. It's also that well known that diabetes is #1 risk factor for developing chronic kidney disease in US. So all patients with diabetes should be started in SGL2 inhibitor. For a patient with reduced glomerular filtration rate, we started with, if the glomerular filtration rate more than 30, we start with metformin and SGL2 inhibitor. This combination showed to decrease the risk of renal, it have renal protection and decrease the deterioration. SGL2 inhibitor, it is started even if, we said before, even if hemoglobin A1C is well controlled. Regardless of hemoglobin A1C, if it is well controlled or not, we should start in SGL2 inhibitor to prevent the deterioration of renal function. Then if we have ejection glomerular filtration rate from 20 to 30, we should stop metformin as it causes lactic acidosis. We use DBB4 and SGL2 inhibitor, which is dapagliflozin or imigliflozin. As we said, we should stop metformin because it increases lactic acidosis, and SGL2 inhibitor should be started. If not patient already on it, we should start it to prevent the deterioration. But if we have glomerular filtration rate less than 20, then SGL2 inhibitor show limited evidence. So we mainly targeting control the glycemic with DBB4, and if the patient need more tight control of glucose level, we can add insulin. So if the patient have glomerular filtration rate above 20, SGL2 inhibitor show to have a great evidence in decreasing the deterioration of renal function. But if glomerular filtration rate less than 20, SGL2 have limited evidence. Now we going to monitoring and safety, hemoglobin A1C assessment every 3 to 6 months, and then every 6 months after we establish well control hemoglobin A1C, we can do hemoglobin A1C every 6 months. Continue glucose monitoring based on the patient condition, and if the patient in insulin and have a repeated attack of hypoglycemia, we should continue monitoring the glucose. And DKA risk assessment. One of the major adverse effects of SGL2 inhibitor is it increased risk of DKA in patients. They take it because it reduces the insulin secretion and it increased glucosuria. This makes the patient at a great risk for DKA. So we'll follow up for the patient, and education about the symptom of DKA should be started. Lastly, drug interaction. GLP-1 receptor and agonist and DDP4 should not be combined. They have the same mechanism of action. This make the patient at a great risk of adverse effect. So the key clinical consideration is based on each patient, as we said, individualization for each patient, shared decision making based on each patient, the comorbidities and the risks they have. SGL2 inhibitor should be started as early as possible for cardiovascular and renal protection. Treatment intensification for patients with hemoglobin A1C more than 7.5 and intensification in the frailty based on the patient life expectancy and so on. This is just a summary of what we have said. Individualization target of A1C based on the frailty, hypoglycemic risk, initiation of dual therapy, metformin and SGL2 inhibitor, and monitoring regularly of hemoglobin A1C. This from the guideline, it's summarized all we said today. Hemoglobin A1C target is 6.5 for all individuals with no risk factor. If the patient has a risk of developing recurrent hypoglycemia, then the target hemoglobin A1C is raised to 7. We need an intensify the target and increase the medication if the patient has hemoglobin A1C is more than or equal 7.5. The most important updated guideline is that we focus on the patient individualization care based on the patient comorbid condition, frailty, cardiovascular, renal risk factor, and atherosclerosis cardiovascular disease. We started, if the patient has atherosclerotic cardiovascular disease, we start with metformin and SGL2 inhibitor and semaglutide subcutaneously. This for prevention, SGL2, as we said, for prevention of deterioration of cardiovascular disease. Initial therapy for patients who have no comorbidities start with metformin and SGL2 based on each patient. And then if the patient has heart failure with an ejection fracture, preserve or decrease ejection fracture, we start with metformin and SGL2 inhibitor to prevent the heart failure. And for chronic kidney disease, if glomerular filtration rate more than 30, we start with metformin and SGL2 inhibitor. Glomerular filtration rate from 20 to 30, SGL2 inhibitor, but we stop metformin, shift to DDP4 inhibitor or insulin. And if less than 20, then the SGL2 inhibitor show no evidence. We just control the hemoglobin A1C with DDP4 or insulin. The patient with frailty based on their risk, we start with metformin, then SGL2 inhibitor or DPP4 based on each patient and life expectancy and comorbidities that they have. And early onset of type 2 diabetes, we start with metformin and prioritize it the SGL2 inhibitor. And people with obesity, we start metformin and SGL2 inhibitor. As patients with obesity at increased risk of cardiovascular disease, because of obesity, they have an increased risk of cardiovascular and other comorbidities that increase their risk. SGL2 inhibitor should be started as early as possible. Then we have the monitoring, hemoglobin A1C every 3 to 6 months, and safety assessment for DKA, risk assessment for patients with SGL2, and yeah, that is all in the updated guideline. if you have any question.
Thank you so much for a great presentation. I think this is a very excellent and important update for the management of diabetes. Any questions or comments?
Okay, thank you very much, Dr. Nader. And if you have any question.
If not, thank you again, Dr. Rayan, and we can move on to the next topic. Thank you.
Okay, thank you.
All right, thank you so much, Dr. Rayan. We're going to move forward with the next topic. I'm going to share my screen again, and hopefully everything goes fine. Inshallah. All right. Here we go. All right. Can you see my screen?
Yes.
Okay, perfect. So I'm going to be presenting Syncope in adults, and my name is Eiman Ahmed. So the scale of the problem, so we have 500K annual ED visits, new adult syncope presenting in the US Emergency Department each year, and that's according to the CDC. 6% of hospital admissions, of all hospital admissions, are contributed to syncope, and 25% two-year mortality in patient age 75 or above are also related to syncope, and 10% are related to cardiac syncope in 1 year mortality versus 2% for reflex syncope. So how a drop in cerebral perfusion triggers fainting. So the physiology of a blackout is when a global cerebral blood flow falls below 25 mils per 100 gram per minute. Consciousness is lost within 5 seconds or less. This threshold is reached when mean arterial blood pressure drops below 50, breaching the lower limit of the cerebral autoregulation. Under normal conditions, cerebral autoregulation maintains constant blood flow across an MAP of 50 to 150. So syncope occurs when the system fails. So the warning signs, patient could present with those warning signs or they could not. So 78%, it's usually vagal episodes. And the classical prodromal symptoms are lightheadedness, a sense of embed faint, tunnel vision, progressive visual field narrowing, nausea or diaphoresis, which is an autonomic surge before collapse, and pallor and weakness is a visible cardiovascular withdrawal. In the other hand, which is the 12%, usually due to a cardiac event, the silent drop. They don't have these symptoms. They just lose consciousness without any signs or any symptoms. So in 12% of cardiac arrhythmia-related syncope event, loss of pulse or tone occurs within any warning. So it's sudden, unpredictable, and high risk, according to Mayo Clinic. So the clinical peer absence of prodrome is a red flag for a cardiac etiology. Always obtain a 12-lead ECG in these patients. So in case of the prodromal symptoms, reported in 78% of the vasovagal episodes, and given patient a critical window to avoid injury. So how do you evaluate these patients when they come to the ER or the emergency department? So we need to take a history from these patients. We need to examine them, and we also need to have some lab and imaging going on. So in regards to the history, we need to ask about, as we said, prodromal symptoms like chest pain, palpitation, dyspnea, diaphoresis, nausea, vomiting, also the eatings, urination, coughing, the medication that patient is using, any emotional stress, any physical exertion, and any turning heads. In the history as well, we need to talk about the also medications. So we are right here at this algorithm. So we need to talk about medication, when do they take it, how they take it, and the dosing. And we have to pay close attention to medication that cause bradycardia and also hypotension. We need to talk about relationships to meal and activities and recent changes. Also very important to know if there's any witness who was there during the episode or the event. And also if the patient has any other comorbidities, conditions like CAD or diabetes. So in the examination, we need to, of course, measure their blood pressure in both arms and make sure that we take this blood pressure standing and sitting. Also, carotid pulse examination. We see if there's any delayed upstroke, perform cardiac massage only with continuous ECG and resuscitation equipment available. So the causes could be, and then when we examine these patients, we have to make sure that we do a thorough CNS and cardiac examination, because these are the two areas of concern as well. So for the neurological, we want to make sure there's no any focal deficit, any visual acuity, the coordination, the gait of this patient. And cardiac examination, of course, we're looking for any kind of a murmur going on. So for the cardiac details, we are worried about something like arrhythmias, obstructive structural lesions, a PE, ventricular tachyarrhythmia, or reduced intravascular volume. So these are the things that we put in back of our heads. So in case of bradyarrhythmias, high-grade AV block or sinus node dysfunction, pacemaker responsive in 85% of an appropriately selected patients, often silent on resting ECG, Holter or implemental loop record required. Obstructive structural lesions. So what are we talking about here? Stenosis, any kind of like severe aortic stenosis that could be a cause of a syncope, and these patients usually have a 2 to 3 mortality, more than 30% without intervention. Also a sudden massive PE, which accounts for 1% of patients with syncope. Ventricular tachyarrhythmia, I apologize again for the sound, the voice on my background. The ventricular tachyarrhythmias, the VTs or Torsades points. And as we know, these could be related to medication or could not. We need to look into that as well. And ICD implementation reduced 5-year mortality from 22% to 8% in high-risk patients. Screen with electrophysiological studies when suspected. There are other causes like bleeding, dehydration. That's why we need to check the patient for occult blood to see if this patient is bleeding from anywhere, and of course, if this patient is dehydrated. So again, as we just mentioned, that there are 3 villain families. Neurally mediated, that's the reflux, and vagal syncope triggered by pain, prolonged standing, or emotional stress. And this is where our history will play a very important role to figure out. Most common in patients whom are, less than 40 years old or 40, accounting to 30% of all cases. Generally benign but recurrent. Also, another cause could be orthostatic hypotension, And again, our history will play a very important role to figure that out. And of course, with examining the patient, but if look into the medication that patient takes and the dosing to make sure that this is not a role that could be causing what we have here. So defined as 20 or less than 20 systolic drop within 3 minutes of standing. Prevalence raised dramatically to 35% in patients whom are 80 years old or above. They're often, as I mentioned, drug related. Cardiac syncope is structural, as we just mentioned, like aortic stenosis, HCM, or arrhythmias, that's the VT, AV block, could play a role in this category. Account for only 15% of episodes, but a disproportionate 60% of syncope-related mortality. We spoke about the classical vago-vagal. Again, they present with nausea, pallor before collapse, managed with counter pressure maneuvers like leg crossing, hand grip. With proper patient education, recurrence falls to 10%. Carotid sinus hypersensitivity, syncope triggered by neck pressure, shaving, tight collars, diagnosed by a pulse at 3, pause of carotid massage, dual chamber pacemaker provided, and 75% symptoms relief. Drug-induced orthostats, those are the antihypertensive, the diuretics, the nitrates, are big players in drug-induced orthostats. Withdrawal or dose reduction resolves 60% of cases, always perform a full medication reconciliation. So the history will play a very good role on figuring out or differentiating the difference between all of them. Diagnosing, testing. So a comprehensive diagnostic framework for syncope evaluation, incorporating a range of tests to pinpoint underlying cause and guide management. So for orthostatic vital signs, finding systolic blood pressure drops, as we said, 20 or less, diagnoses primary orthostatic hypotension, demonstrate extent of dysfunction with positional changes in orthostatic intolerance. Gait evaluation, finding gait unsteadiness, failure of the heart rate to increase. So this increases risk for falls, chronotrophic incompetence, and predicts inappropriate sinus node response. The carotid sinus massage, reproducible symptoms, contraindicated in patient with carotid bruits or history of stroke. Patient with carotid sinus hypersensitivity benefit from pacemaker placement, limited utility. So treatment playbook tailored to, of course, the villain, the 3 villains that we spoke about. So we, depending on what's the cause, we will target it. So the acute management will be supine position with leg raise and supplemental oxygen if needed. 1 liter of steroid IV for orthostatic or vasovagal episode, continuous cardiac monitoring until etiology is confirmed. So the vago-vagal reflex education, physical counter pressure maneuver, this is the first line, and midodrine 5 milligram TID for refractory cases. Orthostatic, these are the treatment we'll give these patients the fludrocortisone and then compressions stockings and then medication review and dose reduction. For the cardiac, the high acuity, the pacemaker for symptomatic bradyarrhythmia, which is 80% response rate, ICD for VT-VF risk, reduce 5 years mortality from 22 to 8%, and TAV or AVR, those the aortic valve replacement for severe AS aortic stenosis with syncope, and the medication we said beta blocker, midodrine, and pyridostigmine. And these are my references. Anyone has any question?
Hello, hi, Iman. Thanks for the presentation. I'm just wondering if there is any recent guideline that targeting when should we use ECG for patients who has fainted or has loss of consciousness. Do I always have to do some ECG or is there is indication for that? Thank you.
So the question was, when should I use the ECG for a patient with syncope? Did I
Yes,
understand you?
exactly. Yes, I'm asking for the guideline regarding using ACD with patients with fainting. Yes.
So what I have looked into was mainly patients with the sensitive carotid, or they usually advise to use the ECG on that kind of patients. So mainly if it's cardiac related.
Yeah, that's exactly my question. Like, how do I suspect it's a cardiac etiology, not just a vagovagal? You previously mentioned that with vagovagal syncope, there is some sort of a prodromal symptoms like tunnel vision or lightheadedness or so.
Yes,
Is
yes.
it always that way, or it can, you know, if the patient has a prodromal symptoms, is that always mean that is it is not cardiac, but it is vagal? I just want to know this exact
Okay,
point.
so yeah, so sometimes they do, of course, overlap, but usually mainly cardiac presentation is a silent drop. What will differentiate both of them is the ECG. This is where it's going to come in place, because that's going to show if there's any bradycardia, any VTAC, any blockage, any arrhythmia. Of course, patients presenting with different or non-cardial causes will not have these kind of findings. I hope I did answer what you were
Okay,
looking
so
for.
basically ECG is mandatory.
Um, ECG is not better.
No, I said ECG is mandatory for every patient with syncopal attack. Is that like this, or
To
it depends
differentiate,
on the case?
yeah, to
So
differentiate
it's
between,
mandatory.
I'm not going to use the word mandatory, but it's to differentiate between the causes of syncope and to make sure this is a cardiac syncope, because patient presenting with syncope, you don't have an idea about that patient. You need to dig into history to see if it's, as I mentioned, related to any kind of like medication. Is it related to neurally mediated orthostatic hypertension, or is it cardiac? And for cardiac, of course, when you do an ECG, that will shows if there's any structural issue, arrhythmia, or any other causes.
Mm,
Did I answer
okay.
you?
I feel confused, but that's okay. Thank you so much. Yeah,
I tried my best. Okay.
thank you so much.
Thank you so much, Dr. Iman, for great presentation. Yeah, and it is an important topic as well, and it's
Yeah.
very common. And as you see older patients, you may have some of these symptoms or episodes. And usually in geriatric, we blame the medication, the very thing, and then we go to the next step. But thank you so much, Iman, Dr. Iman.
Thank you. You're welcome. So our next presenter, Dr. Malaz, are you here?
Hello? Yes.
Okay, perfect. You can go ahead.
Okay, let me to share my screen first. Is it clear?
Yes, it is.
Okay, first, good evening, everyone. First of all, I would like to thank Dr. Nadir and Dr. Imam for giving me this opportunity to present today. And thank you also, Dr. Nadir, for your continuous mentorship and support through this fellowship. I truly appreciate being part of this inspiring learning environment, and I'm grateful for the chance to discuss such as important and evolving topic in clinical medicine. Today, I'll be talking about a very timely update in women's health, the recent FDA decision to remove outdated boxed warnings from menopausal hormonal therapy. Um, Now, if we think back over the past 2 decades, hormone therapy, particularly estrogen therapy, has often been approached with a great deal of caution. Much of his caution originated after the publication of the Women's Health initiative trial, which significantly influenced how clinicians prescribed hormone therapy and how patients perceived its risk. Because of that, many women either never started hormone therapy or discontinued it early, mainly due to concerns about cardiovascular disease, thromboembolism, breast cancer, and dementia. And however, as research has continued over the years, our understanding of hormone therapy has gradually evolved. We have come to realize that the risk and benefits come to realize that the risk and benefits of treatment are far more nuanced than we initially thought, and that they depend on several important factors, including the patient's age, the timing of therapy initiation, the type of hormone therapy used, and even the route of administration. And this is exactly where the recent FDA updates becomes particularly important. The decision to remove these boxed warnings reflects a more updated interpretation of the available evidence and highlights the need for a more individualized and balanced approach when considering hormone therapy. So in this presentation, I will briefly walk through what has actually changed in the FDA labeling, the scientific context behind these changes, and most importantly, what these updates mean for us in everyday clinical practice when counseling and managing our patients. Because at the end of the day, the questions we are facing today is no longer simply whether hormone therapy is safe or unsafe. Rather, the real question is who benefits from hormone therapy, when should it be initiated, and how can we use it safely and effectively for patients sitting in front of us. And with that in mind, let's start by looking at the FDA update itself. As we know, for many years, estrogen therapy has carried boxed warnings, which are the strongest safety warnings placed on medications. These warnings were designed to highlight potential risks such as cardiovascular disease, venous thromboembolism, breast cancer, and even probable dementia. And because of that, many clinicians and, of course, many patients became understandably cautious about the use of hormone therapy. However, as research continued over the years and we gradually started to realize is that cautions, that situations were actually more complex than those original warnings suggested. Much of concerns, as we know, originated from the World Women's Health Initiative study, which was a very important and influential trial. But at the same time, the population studied in WHI had an average age of around 63 years, meaning that many of the women were already well beyond the early menopausal period when therapy was initiated. And this is where things became particularly interesting because we now understand that timing of hormonal therapy initiation really matters. So starting therapy closer to menopause may have a very different risk-benefit profile compared to starting it many years later. So in addition, the WHI study did not fully account for several factors that we now recognize as important, such as differences between oral and transdermal estrogen, or the differences between synthetic progestins and micronized progesterone. So as more evidence accumulated over time, it becomes increasingly clear that applying the same boxed warnings across all types of estrogen therapy was probably an oversimplification of a much more nuanced clinical reality. And this is exactly why the FDA recently decided to update the labeling of menopausal hormonal therapy. Significantly, the FDA removed these outdated boxed warnings from both systematic estrogen therapies and vaginal estrogen therapies in order to better align the labeling with the current scientific evidence. So, this does not mean that hormonal therapy is completely risk-free. Rather, what this update emphasizes is something we already practice in clinical medicine, which is the importance of individualized risk-benefit assessment for each patient. So, and this change has important implications for how we accumulate risk to patients, how we interpret the evidence, and how we make treatment decisions in everyday clinical practice. So, building on the FDA update, this slide simply highlights the specific boxed warnings that have now been removed. These warnings previously addressed concerns related to cardiovascular disease, venous thromboembolism, breast cancer, and probable dementia. With the updated FDA labeling, these boxed warnings are no longer applied broadly to estrogen therapies. And importantly, this change applies to both systemic estrogen therapies and vaginal estrogen therapies. So essentially, what the FDA is doing here is moving away from uniform warning across all hormone therapies and instead allowing the risk profile to be interpreted within the appropriate clinical context. So now, we have talked about the removal of box warnings. It's actually very important to pause for a moment and ask an important question. Where did these warnings come from in the first place? As we know, much of the concerns surrounding hormone therapy over the past 2 decades are largely based on the findings of the Women's Health Initiative, or WHI. This was a landmark study, and it had influence on clinical practice worldwide. After its publication, prescribing patterns for hormone therapy changing dramatically, and many clinicians understandably became much more cautious when considering estrogen therapy for their patients. However, as we look more closely at the design of the WHI study, we start recognizing some important limitations that help explain why the interpretation of its results have evolved over time. First, the mean age of the participants was about 63 years. Now, that may not sound like a big difference at first, but clinically, it actually matters a lot because many of these women were well beyond the early menopausal transition, meaning that hormonal therapy was being initiated many years after menopause had already occurred. And as we now understand much better today, the timing of hormone therapy initiation plays a crucial role in determining its risk-benefit profile. In other words, meaning starting hormone therapy closer to the onset of menopausal may have a very different effect compared with starting it 10 or 15 years later. Another important point is that the WHI population represented an older postmenopausal population, which may not fully reflect the patients we often see in clinical practice, particularly women who are just beginning to experience menopausal symptoms. In addition, the study did not fully differentiate between several factors that we now recognize as clinically relevant, such as different estrogen formulation, different progestins, or different routes of administration. So when we put all of this together, it becomes clear that applying the WHI findings broadly to all women considering hormone therapy may have oversimplified a much more complex clinical situation. And this evolving understanding is exactly what has led to more recent reassessment of hormone therapy risk, including the FDA's decisions to update the labeling and remove the outdated boxed warnings. So essentially, what we are seeing now is a shift toward a more nuanced and individualized interpretation of the evidence. So now let's move to vaginal estrogen therapy, which is actually one of the areas where there are still many misconceptions in clinical practice. As we know, many postmenopausal women develop symptoms related to genitourinary symptoms of menopause, or GCM. So these symptoms may include vaginal dryness, irritation, hot flashes, and sometimes urinary symptoms such as urgency or recurrent urinary tract infections. And for many women, these symptoms can significantly affect quality of life and daily comfort. This is where vaginal estrogen therapy becomes particularly useful. Unlike systemic hormone therapy, vaginal estrogen is designed to act locally and on the vaginal issues, helping restore the vaginal epithelium, improve lubrication, and reverse the atrophic change that occur after menopause. One of the key reasons it's considered safe is that systemic absorption is minimal. In other words, mean only a very small amount of estrogen actually enters the bloodstream, so the systemic hormone exposure remains extremely limited. And this is an important point clinically because the systemic risks that we often worry about with oral or systemic estrogen therapy do not really apply in the same way to vaginal preparations. Because of this minimal systemic exposure, vaginal estrogen generally has a very favorable safety profile. And this is why major professional organizations, including the American College of Obstetrician and Gynecologists and the Menopause Society, support its use for treating genitourinary symptoms of menopause. Another interesting point, and one that sometimes surprises clinicians, is that in carefully selected cases, vaginal estrogen may even be considered in women with a history of estrogen receptor positive breast cancer. Of course, these decisions are usually made in collaborations with the patient's oncology team after carefully weighing the potential risk and benefit. So overall, estrogen therapy is often a highly effective and relatively safe option for managing genitourinary symptoms of menopause. And this is exactly why the removal of boxes warnings is so important, because those warnings often created unnecessary fear, both for clinicians and for patients. By updating the labeling, the FDA is essentially allowing us to discuss vaginal estrogen with patients in a more balanced, evidence-based way. So while vaginal estrogen is primarily a local therapy with minimal systemic exposure, discussions become more complex when we talk about systemic estrogen therapy, where factors like patient age, timing of initiation, and formulation start to play a much larger role. So when we talk about systemic hormone therapy, we are referring to estrogen that enters the circulation and affects multiple organ systems, including the cardiovascular system, the brain, the bones, and metabolic system. And because of this broader physiological impact, the risk-benefit balance of the systemic estrogen therapy is strongly influenced by patient-specific factors. In other words, systemic hormone therapy is not inherently good or bad. Its safety really depends on who the patient is and when the therapy is started. So the first factor we considered is patient age. Younger postmenopausal women is specifically those who are closer to menopause generally tend to have a more favorable response to hormone therapy, both in terms of symptoms controls and overall risk profile. And this brings us to the second and perhaps one of the important factors, timing of limitation. As we have learned from subsequent analysis of the WHI and other studies, the timing of hormone therapy initiation relative to menopause appears to be crucial. When therapy is started closer to onset of menopause, the cardiovascular system may actually respond differently compared to starting therapy much later in life. The concept is commonly referred to as the timing hypothesis or the window of opportunity. The idea is there may be a period early after menopause when estrogen therapy may provide benefits, particularly in terms of symptoms relief and possibly cardiovascular health, whereas starting therapy much later may not provide the same benefits and could potentially carry higher risks. Another factor we have to consider is hormone formulation. Not all estrogen therapies are identical. Different types of estrogen and different progesterones may have distinct biological effects, particularly in terms of metabolic and breast tissue responses. And finally, and often underparticipated factors is the route of administration. For example, oral estrogen undergoes first pass metabolism in liver, which can influence coagulation factors and lipid metabolism. So in contrast, transdermal estrogen bypass the liver, which may reduce some of thrombotic risk associated with oral preparation. So when we bring all these elements together, patient age, timing of initiation, hormone formulation, and route of administration, it becomes clear that systemic hormone therapy cannot be approached with a single universal law. And this is exactly the message that the FDA is emphasizing with the update labeling. Rather than applying the same warning to every patient, the focus now shifts toward individualized treatment decisions where clinicians carefully evaluate the patient's symptoms, risk profile, and therapeutic goals before initiating therapy. So essentially, the conversation around hormone therapy is evolving from fear-based approach to a more nuanced, evidence-based clinical decision-making process. So now this brings us to one of the most important concepts in the entire discussion around menopausal hormone therapy, and that is timing of initiation. As we know, the question is no longer simply whether hormone therapy should be used or not used. What really matters is when it is started, and this is exactly where the concept of the window of opportunity comes in. What we understand now from more recent evidence is that hormone therapy tends to have the most favorable benefit-risk profile when it's initiated in women who are younger than 60 years old or within about 10 years of menopause onset. And why does that matter? Because the body's physiological response to estrogens appears to be very different early in the menopausal transitions compared with much later in life. In the earlier years around menopause, whether during premenopause or soon after menopause, the vascular system, the endothelium, and even metabolic pathway may still be in a state where hormone therapy can provide so meaningful symptom relief, and in some cases may also have a more favorable overall clinical profile. So in this early initiation group, we often think about women who are symptomatic, relatively close to menopause, and who may experience the greatest benefit from therapy. That is why on this slide, the left slide represents hello?
We can hear you.
Can you
Yes,
hear
Dr.
me?
Malaz. Yes, we can.
So at that point, the vascular system may already have undergone changes related to aging, endothelial dysfunctions, or atherosclerotic progression. So instead of providing the same balance of benefit, later initiation may be associated with more limited benefit and potentially greater risk, especially depending on the patient's comorbidities and cardiovascular profile. And this is why exactly the FDA update is so important, because it moves us away from broad generalized messaging and toward a much important time-sensitive clinical interpretation of hormonal therapy. So when we think about hormone therapy today, we should not just ask, does this patient want treatment? We also need to ask, where is she in relation to menopause? How old is she? And this is the right time to initiate therapy. And that is really the key message of this slide. Timing is not just one detail among many. Timing is central to how we interpret both risks and the benefits of hormone therapy. So ultimately, whether we are considering initiation early or later, the decision is still come back to what we do every day in clinical medicine, which is to weigh risk and benefits on an individual basis. So now after going through FDA update, is the removal of boxed warnings, the limitations of the other evidence, and the importance of timing and route of the therapy. The next very practical question is, what does all of this actually mean for us in real clinical practice? And I think this is where the discussion becomes especially important, because for many years, one of the biggest consequences of those boxed warnings was the amount of fear they created around estrogen therapy. As we know, once medication carries a boxed warning, the message often becomes very powerful, not only for patients, but also for us as clinicians. So over time, many women came to associate estrogen therapy almost automatically with serious harm, and many clinicians also became understandably hesitant to prescribe it, even in situations where it may have been appropriate and beneficial. And this is why the first major clinical implication of this update is the reduction of unnecessary fears surrounding estrogen therapy. Not because we are saying hormone therapy is harmless, but because we are now communicating risk in a way that is more accurate, more balanced, and more clinically meaningful. And once fear is reduced, something very important becomes possible again, and that is better clinician-patient counseling. Because when patients are no longer overwhelmed by rigid warning language, we are better able to have a real conversation with them. We can discuss their symptoms, their goals, their concerns, and their individual risk profile in a much more thoughtful way. So instead of simply saying this is dangerous or this is safe, we can say, let's look at your situation specifically. Let's think about your age, where you are in relation to menopause, what symptoms you are experiencing, and whether this treatment makes sense for you. And that leads directly to the third point on this slide, which is the emphasizes on individualized treatment. And really, this is one of the strongest message of the entire FDA update. Because as we have seen throughout this presentation, hormone therapy is not something we should judge with one broad statement. Its safety and usefulness depend on multiple factors, including patient age, timing of initiation, the type of estrogen used, the route of administration, and the overall clinical context. So what the FDA is reinforcing here is something that good clinical practice already teach us. We should treat the patient in front of us, not just the label on the medication. At the same time, it's equally important to say that this update should not be misunderstood. And this is why the final point on the slide is so important. We must still avoid indiscriminate prescribing. In other words, removing the boxed warnings does not mean estrogen should now be given broadly to everyone. It means that the decision should be made more carefully, more intelligently, and more individually. For example, if a younger symptomatic woman presents early after menopause, the discussion may look very different from that of a woman who is older, many years beyond menopause, or has a more complex cardiovascular or oncologic history. So the real clinical implication here is not prescribe more estrogen. Their implication is prescribe more appropriately. And I think that is really the most important takeaway from this entire update. It allows us to move away from fear-based practice and toward a more evidence-based, patient-centered, and individualized approach to menopausal hormonal therapy. So now, as we reach the conclusion of this discussion, I think the key message from this FDA updates became very clear. For many years, menopausal hormone therapy was surrounded by significant cautions, largely driven by early interpretation of large studies such as the Women's Health Initiative. However, as our scientific understanding has evolved, it has become increasingly clear that the risk of hormone therapy are not uniform for every patient, and that many of the earlier warnings did not fully reflect the complexity of real clinical practice. And this is exactly why the FDA has now removed these outdated boxed warnings. This update reflects a broader shift in medicine, moving away from rigid generalized warnings and toward a more evidence-based and individualized approach to treatment. What this means for us as clinicians is the hormone therapy should no longer be viewed through a single lens of fear. Instead, it should be approached thoughtfully, considering the patient's age, timing of therapy initiation, the type of hormone therapy used, and the individual clinical context. So the real takeaway from this update is not simply the estrogen therapy is safer, but rather that our understanding of how to use it appropriately has become more refined. And ultimately, the goal is not to prescribe more hormone therapy or less hormone therapy, but to prescribe it intelligently, more thoughtfully, and more individually. And perhaps the most important message for us as clinicians is this: our responsibility is not simply to follow warnings, but to understand the evidence, interpret it carefully, and provide best possible care for every patient we see. And by the end, good medicine is not about rigid rules. It's about informed decision, thoughtful judgment, and truly patient-centered care. Thank you so much, and I'll be happy if anyone has any questions.
Thank you so much, Dr. Malaz, for this great presentation. And I'd like just to add one comment is that the Women Health Initiative, or the study that started, as you said, a couple of decades ago, it's a big study, and they used it for different topics, cardiovascular and many other conditions, and it was very, very helpful to understand some of the guidelines when they started using this to help understand some of the disease and conditions. So it started with one idea, but the idea was converted into asking others to get involved from the medical field, like the nursing staff and so on. And it built on that, and today it's going on. So this is one point. So you can have an idea about something for your cohort, and this idea, if you work on it, you may find some people who are interested, some people who are willing to volunteer, and this may take a long time, and hopefully it will help all human beings. The other point I want to raise is that as Dr. Malaz mentioned, this showed us that there is no rigid thing in medicine. You can revisit any guidelines or any concept or any instructions or rules, and then see if there is any way of understanding it better, and if there is any changes that can be made to help human beings. So in this program, for instance, the options for you guys to look at things that are done in the past and see if there is anything that we can improve or readdress and study more, or in your future when you join residency or faculty staff member, for example. I want you to understand that medicine is evolving, and you can contribute, you can get an idea and work on that idea, even if that means challenging ideas before you. Hopefully this is clear for you. But again, thank you so much for Dr. Malaz for great presentation. Any questions or comments to Dr. Malaz? Please go.
Thank you so much, Dr. Nadir, for the valuable addition.
Thank you once again. And if there is no more questions or comments, please go ahead, Dr. Mohammed, when you are ready.
Yeah, hello everyone. Just let me share my screen. Okay, I hope all of you can see my screen. Okay. My name is Dr. Mohammed Makkawi. I'll be presenting interesting topic about what are the legal do and don'ts that a doctor should do whenever he's facing a situation outside the hospital, if there is any emergency situation that happens outside the hospital. So let's say that you're driving around the road, and on the side of the road you found someone who is unconscious. So you're thinking, should I render help or not? So in the US, most of the states, legally, I'm talking about legally, you are not required to stop and render aid in terms of the law. Like you don't have to stop and assist if you're in such a situation. How that is in the legally, but ethically, of course, it's considered wrong that we have to help, because that's the part of our oath that we have taken as doctors. But legally speaking, we are not required to stop. Some states have that you have to help, but these are situational. Some states have this exception. Then there is a concept known as half rescue. So let's say, for example, if there is someone who is about to drown, let's take a general situation, about to drown, and you went inside and you want to rescue him, but you realize that you don't like that person and you leave him to his fate. So that's called a half rescue, that you want to attempt to help somebody, but you didn't complete it to the end. So completely. So you should, because you prevented others from attempting to rescue because of your half rescue. So I will go more about it in the next slides. I just wanted to just give a brief introduction about it. Then I'm sure that most of you have heard about the Good Samaritan law. So basically what this law is, it offers protection for those who are giving reasonable assistance to someone. And this applies not just to doctors, but to even the common layman. So usually, because of this law, one is able to act and render assistance to people, and they will not be immune to persecution. However, there are some exceptions to this law, so we should be very clear about it. There is gross negligence, like if someone, for example, knows how to do CPR, you should be able to do it. You should be able to do it correctly in the proper steps. Like if you're not doing it proper chest compressions, you most likely you will be liable, because you prevented others from doing it properly. So by you doing it improperly, you prevented proper care for the patient. So this is considered gross negligence, and by this it will be persecuted by law. And then intentional injury. If you put on purpose with intent that you injure the person, you will also not be exempted by this law and will be persecuted by it. Then lastly, we should know that this law applies only if you're outside the hospital, not inside the hospital. So in the hospital, we have different rules, different laws, but the Good Samaritan law does not apply when you're a doctor who's working in a hospital. It only applies if you're outside the hospital setting. Okay. Then there is an interesting scenario. Let's say you're an anesthetist resident. So as an anesthetist, you're equipped to in your training. You learn how to do lines. You learn how to do intubation. So the question becomes, should I always carry with me such tools, so that in case if I am outside and I need to do such a procedure, should I carry it with me or not? So here it's like, if you can carry such tools with you, but you're not required by law to always have them. And if you do them, if you're very familiar and confident in your skills, their protection from the Good Samaritan law also applies when you proceed with such procedures. Then let's say that you decide to act in such a particular situation. Find someone collapsed. So what you should do? The first thing that you have to do is always you have to announce that you are a physician, so that those who are non-physicians will leave the patient to you. Because if someone collapses, usually there will be some who are physicians, some who are not laymen. So if they hear that you are a physician, they will leave the patient to you. Then you also have to indicate your expertise. So if you are like a psychiatrist or a dermatologist, you have to say that you are such a specialist. This is mainly also to form as a form of protection for you from legal action. So it's important that you have to announce what expertise you are. Then this is a common thing that you might have seen in many shows. You just find someone who's trying to help a patient, just simply shouts, "Someone call 911." This is wrong. We have to always point out to someone, say, "You call 911." You should not just randomly shout, "Somebody call 911." Then nobody will know, or no one will know who should call, who should not call. So it will just cause confusion. So you should always point out to someone and say, "You call 911." Then the famous plane issues. I'm sure that you may have seen scenarios of many doctors who are in planes, and then some emergency happens, and then they call, "Is there a doctor on the plane?" So what is the legal implications in such a situation? So first thing, we have to understand that the state laws, which usually protect you, here don't apply when you are in the plane, because you have different jurisdiction based on which area you are, where are you geographically. So it actually affects. That's why state laws by themselves, they are not protective when you try to assist a patient in the plane. However, it is important to keep in mind that usually when you render assistance in a patient in the plane, usually you will be in a favorable position. Why? Usually, let's say that, for example, let's say that hopefully it doesn't happen to any of us. Let's say that you are being sued for it, that you have rendered help for the patient, and why did you help? And most of the time, the jury will disregard it. They will say, "No, he is a physician, he's doing his duty, and he wants to help the patient." So most of the time, the jury will disregard it, and you'll be safe from persecution. Just the more important point is sometimes it depends on the airlines. Some airlines, they may provide you, because you have helped this patient, they may give you some sort of compensation. They may give you, for example, extra mileage, complimentary drink, an upgrade to your seat, or something like that. It is just that it's important for you to keep in mind is that you should not accept such compensations. Usually, even if it's a minor compensation, this is like an extra layer of protection. Let's say, for example, the patient that you have treated sued you, and he may have a lawyer who is trying to push your button. So they will say, you have helped this patient only because you had the intention of getting that extra compensation. So that's why he will be able to put you in such a dangerous situation. So to avoid yourself from such an situation, don't accept any compensation if offered by the airlines. Then let's handing over. Let's say that you have found a patient unconscious on the street. You're starting CPR on the patient, and the ambulance, then what you should do. Let's say the ambulance staff came. So since the ambulance staff came, you may be able to hand over the patient, because now someone with appropriate medical training level have come and arrived, and they will take over from you. It is important that when you hand over, you should hand over to someone with appropriate medical training. Like you as a doctor should not hand over it to a layman. You should always hand over to maybe another physician if present in the site, or to the paramedics if they arrive. And if possible, try to chart what happened. because you're not in an official patient doctor-patient relation. So it's important that you document what happened during those 5-10 minutes that you have been dealing with the patient, at least in the ambulance note, so that if there is any legal issues, you at least have a document saved that you have done so and so, so you will be mostly safe. And then there is the issue of posting in social media. Let's say that you have saved somebody from maybe somebody famous, and he became well. So what legal can I post that I have saved this person from from his situation? Legally, yes, you can post that I have saved this patient. He was ill and I rescued him, and so and so and so. Legally, you can, because there is no doctor-patient relationship establishment, and there is no there is no concern of privacy, because because there is no doctor-patient relationships. So legally, you may be able to post it. However, ethically, one should avoid doing so. It can be considered as a show-off, and sometimes backlash may arise. Like if you put it in the media, backlash may come to you. They will say that this doctor only did it for the sake of fame. So to avoid such backlash and such, it's best not to post such things. Then let's say, then what about the one who's rendering help? Is he, if he's a student or a resident or a consultant, at whatever level of expertise is there any difference? Well, by law, there is no difference. The law is still the same between all levels. So you're equally protected as long as if you feel that you're very confident and competent in what you are doing, you should be all right. Just an additional points just to keep in mind. Usually, if it's a layman who does the emergency situation, and then later on he can show off in social media, usually he won't have any backlash. But if it's for example a consultant or like head of department, and he does such a thing, then they are the ones more likely to face backlash. So it's best, again, avoid posting again. And also, usually those who are of higher position, the more higher the one who does the rescuing, is more likely to face lawsuit, even though the lawsuit will most likely fall in your favor because you have done everything by the law. But it doesn't mean that you won't get sued. You can still get sued, even though you will win the lawsuit. It's still a hassle, and you still have to appear for court, and you waste time, you waste effort. So it's best to be discreet. Don't say that I am a consultant in this. Just say that I am a physician and I am of this specialty, just to avoid this hassle. And that's all I have for today. Thank you very much. If you have any questions, I'm ready to answer.
Thank you so much, Dr. Mohammed, for also great presentation. Any comments or any questions or any personal experience that you want to share, guys? Thank you. So I'm gonna share one of my experiences. I was on a flight coming to the US, and one of the passengers had episode of chest pain, and I was asked to help along with another physician. So you may come across something like that or this situation. So as Dr. Muhammad laid it very clear that by law you are not required to, but it's in medicine you have an oath, and if you want to help, if you have the know how, and these are the steps. Introduce yourself. You are a physician, and you want to help. And as mentioned, if you have a specialty, you can mention that and do your best. And if you can, after the event, document that so that in case someone asks you in the future, you have some record to refer to. But thank you so much, Dr. Mohammed.
Thank you very much, doctor.
If no more questions, we can move on to the last topic, which is the updates. Please share your news if you have any new update, or if you have just questions about the fellowship, new ideas, and so on. Dr. Eiman, go ahead.
Yes, for the project update, we are working currently on an AI documentation scoping review. So we are done with the data extraction part of the project, and we are at the analysis part right now. So that's about it. Very interesting topic.
Great, excellent. Thank you so much for the update. Anyone else?
Yes, we are working on a poster for the AIC. It's regarding the glucose monitoring, and yes, we are working on that.
Excellent. Thanks for the update. And, wishing you all the best, guys.
Thank you, Doctor.
Any other update or any other questions or ideas in general for this program, or your projects, or anything that we can help you with, or modify or change or improve? If there's any new fellows, do you have any questions? If not, I'd like to thank you all for attending this meeting. Thank you, Dr. Eiman and your team, for great presentations. If you want to add your comment, Dr. Eiman, please go ahead.
No, I just want to thank you so much for your time and for giving us this platform. We really do appreciate it.
Thank you again. It's my pleasure. And we'll see you next week. If you have any questions, please email, contact me via text, call, or WhatsApp. And we'll see you next week. And also, I'd like to thank those who will watch the recording in the future. Have a wonderful day. Ramadan Mubarak, and see you next week. Assalamu alaikum.
Thank you.
Walaikum assalam. Thank you, Dr. Nadir. Thank you, Dr. Eiman, and your group for this great presentation.
Thank you, Dr. Azza.
Thank you.
Thank you very much.
Thank you, Dr. Mohammed. Have a wonderful day.